Gawing co-host si Nemo.
Apa, Dok, apa. Ikaw din pala, Dok, no? Yes, yan, naka-co-host ka na.
Hello? Hello.
Hello.
We start? Can we start?
Isaac, yes, we could start.
Hello,
Okay.
Jan.
Hi. Beautiful and safe evening to you all. I would like to thank everyone for joining us tonight in this inaugural webinar lecture brought to you by the Philippine Society of Nephrology. I am Dr. Jan Melvin Zapanta from the AUF Medical Center, section of nephrology, and I will be your moderator for tonight's webinar. First, we have a moment of silence and prayer to be led by Dr. Stephanie Andres. Ma'am.
Good evening, everyone. Let us place ourselves in the presence of God. Lord, thank you for gathering us all again after more than 1 year since our last convention. Please bless all our speakers and all of us, the members of the Philippine Society of Nephrology, as we unite ourselves in these webinars and in prayer. So together, may I invite you, let us all pray the Oratio Imperata. God our Father, we come to you in our need to ask your protection against the COVID-19 that has disturbed and even claimed lives. We pray that you guide the people tasked to find cures for this disease and to stem its transmission. Protect the medical experts that they may minister to the sick with competence and compassion. We pray for those afflicted. May they be restored to health soon. Protect those who care for them. Grant eternal rest to those who have died. Give us the grace in this trying time to work for the good of all and to help those in need. We implore you to stop the spread of this virus and to save us from our fears. Grant all these through our Lord Jesus Christ, your Son, who lives and reigns with you in the unity of the Holy Spirit, one God, forever and ever. Amen. We fly to your protection, O Holy Mother of God. Do not despise our petition in our necessities, but deliver us always from all dangers, O glorious and blessed Virgin. Amen. Our Lady, health of the sick, pray for us. Saint Raphael, the Archangel, pray for
Pray
us.
for us.
Saint Roch,
Pray for
pray
us.
for us.
Pray for us.
Saint Lorenzo Ruiz,
Pray for
Pray
us.
for us.
Pray for us.
Saint Pedro Calungsod,
Pray
pray
for
for
us.
us.
Pray for us.
In the name of the Father, the Son, of the Holy Spirit. Amen.
Thank you, Dr. Andres. May I now call on our dear President, Dr. Elizabeth Angelica L. Roasa, to give her opening remarks. Ma'am.
Good evening, everyone. Thank you, Jan. On behalf of the PSN Board of Trustees, I welcome all of you and thank you for your online presence tonight. Since the first quarter of 2020, we have all been facing the challenge of responding effectively to the ever-unfolding COVID pandemic. There are many unknown unknowns. The entire world has been turned upside down. The Philippine Society of Nephrology has not been spared. Current circumstances have forced us to do something that had never been done in the past 49 years of our society's existence. The 39th annual convention scheduled last April had to be canceled. Among the things we are learning these days is the need to change. We are creating a new normal, replacing our routines with substitutes. We need to adapt. The PSN is committed to continue providing the means to continue learning and gaining new knowledge. Currently, it is not just our usual topics. We also have to integrate emerging data on the novel coronavirus and its unprecedented effects on our practice as nephrologists. During these days, dark days, technology is on our side. Technology moves humanity forward, and it more than ever now proves to be the light of hope to keep us connected, informed, and educated. Learning will continue. In adapting to these times, we have to shift the mode of learning and teaching online. Tonight, we recognize the hard work and dedication of the organizing committee of the annual convention, which was canceled. This is led by the indefatigable, the tireless na lang, chair, Dr. Elizabeth Montemayor, and the equally dedicated and committed heads and members of the different committees. I will have to mention Dr. Russell Villanueva and Gladys Diaz. They had been on their toes trying to put all of these together, among others. The list of names is long. Pardon me if I cannot give all your names. We will have to thank all of you, plus those lecturers who have already confirmed and committed to give lectures during our series of webinars. We are deeply grateful for your efforts and the time that you have spent having to plan twice. First for the canceled convention and now again for this series of webinars over the next weeks. Thank you very much. Let your hard work and efforts be not in vain. All of us, please let us try to attend. Let these webinars bear fruit, help fulfill our mission to disseminate current knowledge and information in nephrology. Together, let us virtually come and listen to what they have prepared for us starting tonight. Again, thank you very much.
Thank you, Dr. Roasa. At this point, we would like to thank our industry sponsor for tonight's webinar, Sanofi Philippines. We will briefly have an industry-sponsored lecture on sevelamer. Our speaker is a clinical associate professor in the UP College of Medicine and is currently the training officer of the Department of Nephrology at the National Kidney and Transplant Institute. Please welcome Dr. Anthony Russell T. Villanueva. Sir?
Thank you, John. And I'll just share my screen and would like to thank everyone for joining this important webinar that we have, the first of a series. And of course, extending our gratitude to Sanofi Aventis for providing us the sponsorship for this first web series that we have. So allow me in their behalf to give a lecture on sevelamer beyond the outcomes. This is a module that we made and maybe discuss and learn more on how we could utilize sevelamer and the benefit that it could provide us with our management of our chronic kidney disease patients. So this is the outline of my discussion. We know that hyperphosphatemia has caused a lot of burden in the management of chronic kidney disease cases that we see in our clinic. Phosphate homeostasis follows a delicate balance with our effector organs. We know that it's the intestines that provides the absorption of phosphate with the food that we intake, and also the bone act as a bank for phosphate, managing the influx and efflux of phosphate. And finally, the important organ, the kidney, provides us with the excretion leading to the normal range of phosphate in our serum. Aside from these three organs, we have two proteins that play an important role. They govern phosphate homeostasis. These are the parathyroid hormone and the fibroblast growth factor 23. In the early stages of chronic kidney disease, there is a decrease in the filtered phosphate load leading to the phosphate retention in the body. So by the time that your GFR declines to very low levels, there is overt hyperphosphatemia that will develop. So just a review of the mineral alterations that we see in our body as the kidney progresses among CKD patients and with regards to CKD MBD. So the first alteration that we see is actually an increase in the FGF23 levels as early as a GFR of 75. So the slow increase of FGF23 would lead to a decline in the active vitamin D levels. When you have low vitamin D levels, then there would be an increase in parathyroid hormone due to a feedback mechanism leading to a secondary hyperparathyroidism. And lastly, the net effect is that you would have an increase in serum phosphate concentration. So there are adaptive mechanisms to lower the phosphate in our body, and particularly the high concentrations of these two proteins have developed an adaptive mechanism to lower phosphate levels at that time that this is not really adequately excreted by the body. And it has been seen by international experts and also followed by the CPG and KDIGO that it is recommended that you target their recommendation with regards to phosphate levels. It has been seen that if you're able to target adequate phosphate levels, the survival rate tends to be better as compared to failing to achieve this. And how do we achieve this? Of course, by controlling diet, intestinal absorption of phosphate, and of course, adequate dialysis. So there are a lot of studies that were done comparing the available phosphorus binders that we have in our practice. So we know that the calcium salt is a favorite of most practicing physicians, be it calcium acetate and calcium phosphorus. We also have been using sevelamer in our patients. And comparing the two, it is as efficacious as each other with regards to the outcome of phosphorus lowering. But then again, we should not be happy just seeing our phosphorus levels go down, particularly our CKD patients. We want to see if there are pleiotropic effects or added effects with the use of either drug in our patients. And thus, I would like to give the following slides to further give you more evidence on why sevelamer might be helpful for our patient. Now, the common fear nowadays is vascular calcification among our CKD patients. In fact, it has been called to be the killer in kidney disease. Cardiovascular complications are the leading cause of death among patients with chronic kidney disease. So based on this graph by the USRDS, from 1996 to 2014, the most common cause of death are still cardiovascular in nature, be it acute myocardial infarction, congestive heart failure, cerebrovascular accidents, and even diabetes that leads to endothelial dysfunction, be it microvascular or macrovascular. And they have compared patients who is suffering from chronic kidney disease as opposed to those not with kidney problems. And even with propensity scores or multivariate analysis, that having the same severe risk factors like hypertension, aging, smoking, diabetes, and even an abnormal lipid metabolism, there seems to be more increase in frequency of cardiovascular disease in the kidney patient as opposed to the control group. And this just shows that it might indicate that there is something more than this severe risk factor. There might be a distinct pathogenesis that is involved with regards to this problem in the vasculature. So in Thailand, they did a study reviewing patients with chronic kidney disease using the abdominal aorta calcification. And for moderate to severe CKD, not yet on dialysis, the range comes from 24 to 30% have significant calcification already. And once the patient's on dialysis, it rises to 35%. So vascular calcification also is related to dialysis vintage. The longer that you are in dialysis, the higher the chances of calcification in your major vasculature. And probably because our blood interacts with the not so biocompatible membrane, which is the dialyzer, that leads to inflammation and even certain stress in the vasculature of our CKD patients. And it has been reviewed that if you have a higher calcium score in your coronaries, then there's a higher range of prevalence of atherosclerotic vascular disease. So they've used certain scoring. One popular scoring is the coronary artery calcium score. And if the higher the score that you have, it is predictive of future cardiovascular disease in our patients. So here also, just to share that arterial calcification, so the more arterial beds that are involved, the higher the risks for death. So if you have no arteries that are calcified compared to having 4 arteries that are calcified, it increases your mortality risk by 73%. So in another way to discuss this, that each unit increase of the calcification would increase your all-cause mortality by 1.9 and also by 2.6 for cardiovascular-related mortality. So they have reviewed in a univariate analysis which are the risk factors. Obviously, most of our patients actually on dialysis belong to these demographics: older age, male gender, diabetes, longer dialysis vintage, but higher concentrations of calcium and phosphorus are important risk factors. And that is why we know that the KDOQI guidelines have discussed this. For early stages of chronic kidney disease, aside from lowering the phosphorus, you should just target a normal range of calcium. But let's take note, for those with advanced kidney disease, you don't target the normal range. You actually target the lower limit of normal. They are worried that if any higher level of calcium may make the patient predisposed to this vascular disease. Not only calcium, even phosphate by itself is toxic in a variety of ways. It could lead to endothelial dysfunction and inducing oxidative stress in the cells. High phosphate levels with regards to outcomes can lead to left ventricular hypertrophy, problems in hemoglobin levels, immune dysfunction, skeletal and adipose tissue problems. So just having an increased phosphate, irregardless of your calcium level, also leads to vascular problems. So it is not just by lowering phosphate. They believe that it is modified by other factors like the pH level, calcium concentration, clotostatus, and inflammation. So the story is not just to lower phosphate. We have to address other cofactors of phosphate that leads to damage to the vascular smooth muscle cells. And thus, we see that sevelamer might be an option through its other effects in the body. So it has been shown in this study that giving phosphorus binders improve the survival rate of our CKD patients. Sevelamer is a non-calcium phosphate binder, which is FDA approved for patients with advanced chronic kidney disease for phosphate control. So a lot of different studies have been done, and it shows that it has an action on inflammation. It has also an effect on lowering oxidative stress, better lipid profile, vascular calcification, lowering endothelial function improvement, and also the reduction of several uremic toxins. So in this meta-analysis published in JASN in 2016, they divided the subgroup of patients from sevelamer being pitted against calcium acetate, the first subgroup, then calcium carbonate, the second subgroup, and both calcium salts in the third subgroup. So combining all subgroups, they came up with a conclusion, which is the diamond at the bottom of this forest graph on the left of the line of unity, favoring sevelamer with regards to better outcomes with regards to all-cause mortality in CKD patients. So in this combination of studies, it proves that sevelamer may have an advantage as compared to the calcium salts. Another network meta-analysis was done, and again, sevelamer compared to calcium has an advantage. Endothelial dysfunction also has been reviewed, and we know that most of our CKD patients, along with their comorbidities like diabetes, have widespread endothelial dysfunction. So in this study, they tried to review first the blood chemistry of those receiving sevelamer versus those receiving calcium salt. Both of them significantly decrease phosphate levels, but only sevelamer has addressed cholesterol problems, leading to a drop in LDL and an improvement in HDL, which we all believe is a better environment for our arteries. Furthermore, there is evidence that sevelamer reduces the inflammatory status not seen in the calcium carbonate arm. Sevelamer carbonate significantly decreased systemic inflammation, along with improved lipid profile, and also the endothelial factors that are favorable for patients on dialysis, also suffering from type 2 diabetes, which we believe would be an advantage for them. And aside from this, as explained earlier, that the coronary artery calcium favors a risk for future coronary heart disease events, and sevelamer has an advantage also in improving this, which relates to a better survival outcome. That is why KDIGO already recommended, especially in the presence of hypercalcemia, that restricting the dose of calcium-based phosphate binders but it is also suggested that you restrict the dose of calcium-based phosphate binders or maybe shift to a non-calcium-based phosphate binders in the presence of arterial calcification, along with the other factors mentioned in this slide. So with this effect of sevelamer, it could produce an advantage with reduction of cardiovascular morbidity and mortality. Now we discussed the cost effectiveness of sevelamer use in CKD patients. So this is a nice graph that discusses how we make our decision based on health economics. So the x-axis talk about the less effect of the drug versus an additional effect, while the y-axis talks about the cost, if it's expensive or low in costs. So ideally, we want it somewhere here where there is additional effects and lower costs, but we have what we called in health economics, the WTP, or within threshold of payment. So we're looking for something that has additional effects, which has good value for money. So there was a study done in Korea wherein they compared 500 patients taking sevelamer versus 500 patients taking calcium acetate, and they used the Markov model to see if there is health economic benefit. So first, they've seen that there is a hazards ratio for mortality that is advantageous for sevelamer as compared to calcium acetate. So this is the graph. Furthermore, they analyzed that the total life years are more in a patient receiving sevelamer and as compared to calcium acetate, which also translate to the better QALYs. So there is an expected increase of life years by 1.7, and the quality of life years is equivalent to 1.1 per patient. And this translates to savings for the patient. This is based on US dollars, but during the time that this slide was made, this is the equivalent peso amount. And lastly, just to share with you that there is a new formulation that you may know already, or some may not yet be familiar, is the formulation of sevelamer powder. So they came up with a powdered form because it has some benefit for certain patients. We know that the Renvela sevelamer tablets can be large, and having a powder form can be advantageous in certain populations. So they actually did a head-on trial comparing the tablets versus the powdered form, which is sevelamer carbonate, and it's a crossover trial. So with regards to phosphorus containment, meaning normalizing phosphorus, it is just the same with the use of powder and tablets. So that gives us confidence because the efficacy is just the same. But there seems to be a bit of an advantage of using the powder, at least for this study, because the formulation is not with hydrochloride, but with carbonate. And the use of carbonate, as you can see, increases the level of bicarbonate, which can be an advantage for our patients suffering from acidosis. So having this option for two formulations can be something that we could prescribe to our patients. So practice points, we know that the phosphate bind burden in our patient is quite prevalent, and it is related to mortality. And that is why we have to be active in managing these cases. Vascular calcification up to now, whether you're in non-dialysis CKD, a patient on dialysis, or even the transplant patient, remains to be the major reason of death for our patients. And calcification has to be addressed by not increasing the calcium burden and providing medications that could address inflammation in the vascular beds. And sevelamer is an option not just by lowering phosphate, but also its pleiotropic effects may be beneficial to our patient population. The cost effectiveness has been shown that even if per unit it's a bit more expensive, but with regards to outcomes, at the long term, it will be more beneficial and more cost effective. And lastly, for a certain patient population, there might be an advantage on increasing compliance by providing a prescription of sevelamer powder as opposed to the tablet form. So I hope with this part, I was able to share with you how sevelamer can go beyond the outcomes, not just by lowering phosphate levels, but also certain effects that can be beneficial to the vasculature of our CKD patients. So I'd like to thank everyone for listening. Thank you.
Thank you, Dr. Villanueva, for the brief and informative lecture on sevelamer. And also thank you to our sponsor for tonight's webinar, Sanofi Philippines. Next up, I will give the screen to our next speaker, Dr. Robert Tanchanco, to update us on what the PSN has been doing and studying about COVID-19. Sir?
Good evening, everyone. I hope everyone's healthy and safe. I was asked to talk about the pre-study survey that we did. I'd like to clarify that I am not about to present the study itself. I think that will be done at the proper time by the lead authors, Dr. Vimar Luz and Dr. Arlene Afaga. So I'd like to share with you my screen. Okay, so this is a pre-study survey that we conducted online, of course, and I'm glad to say that quite a number of institutions replied. So this is the description that we gave for the survey itself, that the PSN is conducting a multi-center study on the experience of our training institutions with COVID-19 patients referred to the nephrology service. So for this survey, there were 15 institutions who replied, with a cumulative total of 1,712 COVID patients seen in their institutions. And this is as of April 30, 2020. The last time I checked the survey was in May 18, 2020, and 15 institutions replied, and you see the list of the institutions here on the right-hand side. And there was a cumulative total of 509 patients referred to the nephrology service. So that's 29.7% of all COVID positive patients documented in those institutions. Now what we found, the hospital type, most were private, 60%, and then 40% were government hospitals. And we also asked the laboratory tests that are available in those institutions. And this is what we found out, that most institutions, 73% use creatinine in milligram per deciliter. Calcium, ionized and total are both available in most. The C-reactive protein, most are using, they have both the CRP and the high sensitive CRP. And then the tests that we generally need to suspect or determine the presence of cytokine storm syndrome are also mostly present in the institutions. Now, in terms of hemoperfusion use, we noted that 2/3 of the institutions who answered have used hemoperfusion as a treatment regimen in their COVID-19 patients. And you see on the right-hand graph the cartridges that were used in those institutions. CRRT was used in 46.7% of the institutions who replied. And in terms of heparin use, we see that all of them used heparin as anticoagulation during renal replacement therapy or hemoperfusion. And it has been noted in the literature that patients with COVID-19 tend to be more hypercoagulable. We see more clotting episodes, but we see here the incidence of clotting reported by the institutions, and more than half actually did not note any increase in the incidence of clotting. Now, the COVID therapies that have been tried in those institutions, you see here a rundown. All of them tried hydroxychloroquine or chloroquine as an immunomodulating agent, tocilizumab in 80%, convalescent plasma. This is as of May. I guess if we run this survey again now, the convalescent plasma and remdesivir, since the Solidarity trial has been launched and there are a couple of institutions in the Philippines that are participating, probably see a higher percentage for those. Now, in terms of RAS inhibitor, the attitude towards RAS inhibitor, the guidelines are clear that this should be continued. And that's also true of the survey results, that 91% have that approach with regard to RAS inhibitors. And in terms of being willing to join the study being launched by the PSN, the multi-center study on COVID-19 with renal issues, um, only one institution actually said an outright no, and most said yes or will have to ask permission. Well, actually, all of us will have to ask permission with our ethics committee. So that's the last slide. Thank you.
Thank you, Dr. Tanchanko, for that quick update. Before the webinar proper begins, may I remind everyone, if you have any questions to our speaker about the main lecture, we will be allotting 15 minutes for question and answer after the lecture. For now, kindly type in your questions on the Q&A box below. Our speaker will try to answer all of them later. Thank you very much. Also, may I remind, gonna share my screen. May I remind, technical difficulties. May I also remind all the fellows and diplomates of the Society about the annual business meeting and election of the National and Chapter Board of Trustees on July 12, 2020. Kindly confirm your participation on or before June 15 and ensure that your email address is correct and updated in the PSN database. Now, let me introduce to you our speaker for tonight's lecture. Her lecture is entitled COVID-19 and the Kidneys. She's a well-known nephrologist and physiologist in our country. She is currently the Vice President of the Philippine Society of Nephrology and a professor of the UP College of Medicine and a consultant at the Philippine General Hospital. It is my honor and pleasure to introduce to you one of my mentors, our main speaker for tonight, Dr. Elizabeth S. Montemayor. Take it away, ma'am.
Yeah. Thank you very much, John. I will just share my slides. Okay, thank you very much. And I'd like to thank everyone for their attendance to this first lecture. And the first lecture is on COVID, of course. That's the pandemic. That's the event that changed the course of our lives. So, and for this lecture, I'm going to tell, ayaw mag-move.
Hindi pa siya nakashare.
Yeah. Okay, thank you very much. And so for this lecture, I'm going to talk about the usual kinds of patients that we see. Ayaw pa din. Okay. So this will be the chronic kidney disease patients, especially those who are on ACE/ARB, the kidney transplant patients, the patients on dialysis, and the patients with acute kidney injury. This is a meta-analysis of the preliminary and early data on the COVID positive, on the COVID-19 patients. And they noted that chronic kidney disease patients have this enhanced risk of developing severe COVID-19 disease. So to our patients, we should really tell them to enhance their self-protection and to do all the things that they need to do to prevent them from contracting the disease. Now, we all know from the KDIGO guideline, a strong recommendation for the use of ACE or ARB in almost all our patients, diabetic and non-diabetic kidney kidney patients, especially if they have proteinuria. But what is the relationship of this ACE and ARB to the present pandemic? We will go back to the renin-angiotensin pathway. Okay, so we have this big substrate, angiotensinogen. It's 452 amino acid, which is broken down into a 10 amino acid by renin. And angiotensin 1 is acted upon by angiotensin converting enzyme to angiotensin 2. So angiotensin 2 is an 8 amino acid protein. Now, angiotensin 2 binds to its receptor AT1. It has also an A2 receptor, but it has a propensity for binding to the AT1 receptor. And when angiotensin 2 binds with an angiotensin 1 receptor, then you have those deleterious effects like vasoconstriction, fibrosis, inflammation, thrombosis, and pulmonary damage. So the effect of angiotensin binding to the AT1 receptor is destructive. However, angiotensin 1 can be degraded by an ACE2. So this is also an enzyme, angiotensin converting enzyme 2, to angiotensin 1 to 7. And angiotensin 1 to 7 has a propensity to bind with the MAS receptor. And binding of angiotensin 1 to 7 to the MAS receptor causes vasodilatation, fibrosis, decrease in fibrosis, decrease in inflammation, decrease in thrombosis, and decrease in pulmonary damage. So in other words, the binding of angiotensin 1 to 7 to the MAS receptor counter-regulates the effect of angiotensin 1. Okay. So, however, angiotensin 2, which converts, angiotensin converting enzyme 2 or ACE2, which converts angiotensin 2 to angiotensin 1 to 7, is also expressed in the different organs, central nervous system, the lungs. But now, what is wrong with ACE2 is that it is also the receptor for the coronavirus. Okay? So the ACE2 has two domains, one the N-terminus and the one which is a transmembrane domain, the C-terminus. So it is here in the N-terminus that SARS-CoV-2 tightly binds. And so this is the configuration of the SARS-CoV-2, and the binding occurs in this spike protein, the S protein, and you might just see that it's just like that, but look at this particular figure. It is a very, very, very complex protein. So what happens? When the virus binds on ACE2, it gets endocytosed and is internalized. And here in the internalization part, this is where it multiplies. And so what happens? The ACE2, instead of converting the angiotensin 2 to angiotensin 1 to 7, is utilized by the virus. And so there's a decrease in the ACE2. Now, because of that, there is no degradation of the angiotensin 2, and it's allowed to bind to an angiotensin 1 receptor, and it will do its detrimental effects: fibrosis, increase in reactive oxygen species, hypertrophy, vasoconstriction, and gut dysbiosis. Okay, so we have less of the angiotensin 1 to 7 and less binding to the MAS receptor and less protective effect. So it has been shown that patients, I'll just use a laser pointer. Okay, it has been shown that angiotensin levels in the COVID-19 patients is higher compared to the angiotensin level among the healthy patients. And maybe that is because of the failure of the ACE2 to degrade angiotensin 2 because it has been utilized by the virus. There's another form of ACE2. This is called the soluble ACE2. And that means that the extracellular part pinches off from its transmembrane domain. So you have here a soluble H2, and this can potentially bind with the virus and coat the spikes here. And this will prevent the virus from binding with the transmembrane ACE2 and becomes internalized. So a therapeutic approach here will be the recombinant human soluble ACE2, which can potentially coat the spikes of the virus so that it will not be able to bind with the transmembrane ACE2, and the body's immune system will just take care of that. And that's going to be very important because once the virus gets internalized, it replicates. So it replicates and it produces new virus. So this one can be taken care of by the recombinant human or by the soluble ACE2. Okay, so what's the controversy here? ACE inhibitors and angiotensin II receptor blockers appear to increase the expression of ACE2 receptors. So now the angel here is that you have more angiotensin II, you have more ACE2 to degrade angiotensin and more ACE2 to promote the angiotensin 1 to 7 mass receptor pathway. But the deleterious effect here is that you have now more receptors to the SARS-CoV-2, and therefore there'll be more virus entering the cell and more virus being replicated. So let's look at the studies on the use of ACE-ARB among hypertensive COVID patients. And here, from this more than 1,000 ACE COVID-19 positive patients, more than 300 were hypertensive, more than 100 were on ACE, and more than 200 were on non-ACE. Now, if you're going to look at the mortality rate of the mortality of the hypertensive COVID positive, the mortality is very high compared to the total in-house mortality. But let's look at the ACE-ARB users. There's no difference whether the patient is going to get severe infection or non-severe infection if they are on ACE or ARB. And there's also no difference in terms of surviving or not surviving if you are on ACE or ARB. Okay, let's look at a greater number of patients. There's more than 18,000 patients, a lot of them on ACE, ARBs, and there were 1,735 patients who were COVID positive. Again, what's the outcome here? Whether you are ACE or not on ACE, ARB or not on ARB, there is no increase in the likelihood that you're going to test positive for COVID-19. So there is no increased risk for developing COVID-19 if you're ACE or if you are on ACE or ARB. However, if you are on ACE or on ARB, you have a higher risk for being admitted to a hospital. And if you are on ACE, you have a higher risk of being admitted in the intensive care. However, there's no difference whether you are an ACE-ARB user in terms of ventilator use. Okay. So here's another study comparing mortality between ACE and ARBs. And you can see here that in fact, mortality among the ACE-ARB users is lower compared to the non-ACE-ARB user. So the mortality for the ACE-ARB user is only 3.7%. The mortality for the non-ACE-ARB user is 9.8%, and that's a significant difference. So let's look at the hazards ratio. For all-cause mortality, there is in fact a decreased risk of dying if you're on ACE-ARB. There is no difference if you are an ACE-ARB or not on ACE-ARB for the odds of having septic shock, ARDS, acute kidney injury, or acute heart injury. So really, there's not much deleterious effect on the use of ACE-ARB, except for more admission, more hospital admissions, and more ICU admissions. Now, it has been, this has been the recommendation of the various hypertension societies, that since they cannot find any evidence for discontinuing the use of ACE-ARB, their recommendation is continuing the use of ACE-ARB due to the lack of evidence. However, if you want to be very, very cautious, you have to consider two things here. Is the ACE-ARB being used for long-term benefits, in which case you have already a well-controlled blood pressure and a very stable kidney function, or it is used for the current benefits like severe or uncontrolled hypertension or heart failure? If it is being used for the current benefits, then you have to continue with the use of ACE-ARB. Now, if it's being used for the long-term benefit, and discontinuing this for 1, 2, or 3 weeks, not going to really make any difference, then you can continue if your patient is on standard risk. But if they test positive, you can stop for a while and resume when they have recovered from COVID-19. But if there is high risk for COVID-19, like for example, they are household contacts or they are healthcare workers, you can consider stopping ACE-ARB. And if the patient tests positive for COVID-19, stop and resume once they recover from COVID-19. So to summary, chronic kidney disease is associated with higher risk of severe COVID. We said before, and in the meta-analysis, there is a 3 times increased risk of developing severe COVID-19 among patients who have chronic kidney disease. The receptor for SARS-CoV is ACE2. ACE2 receptors reduce the adverse effects of angiotensin II, not only by degrading angiotensin II, thereby eliminating or limiting its deleterious potential, but also by generating angiotensin 1 to 7, which exerts numerous salutary and opposite or counter-regulatory effects to those of angiotensin II through an efficient binding with the receptor mass and angiotensin II type 2 receptors. Therefore, you have 2 axes here. ACE2 angiotensin 1 to 7 mass receptor axis is counter-regulatory to the ACE angiotensin 2 AT1 receptor axis. However, ACE inhibitors and ARBs upregulate ACE2, and therefore you have more receptors now for the SARS-CoV-2. But the use of ACE-ARB is not associated with increased mortality, but is associated with more hospitalizations and ICU admissions. Now let's go to the kidney transplant patients. This is the Montefiore experience. They had 36 kidney transplant patients with a mean age of 60. And look at the presentation. A lot of them are initially asymptomatic, and the median follow-up was only 21 days. The laboratory findings showed a predominance of lymphopenia, thrombocytopenia, and very low CD3, CD4, and CD8 count. So what's the mortality here? Mortality is high, 28%, including the 2 who were recently transplanted. And these 2 recently transplanted were being managed initially in the outpatient. So it means that they presented with mild symptoms, but eventually deteriorated fast. If the patient is intubated, that's a very high mortality, 64%. And so a lot of patients still remained hospitalized. So you have high mortality here and long period of hospitalization. In the Italian experience, they had 20 kidney transplant patients who were admitted for SARS-CoV pneumonia. Okay? On admission, the immunosuppression was withdrawn, and they started the patient on methylprednisolone alone 16 milligrams, together with the standard of care. Okay. So the course of the patient, you can see that here they have a lot of them had worsening chest x-ray findings, and a lot of them had escalation of oxygen supplemental therapy. And what is the outcome here? 25% death, 6/20 with AKI, and 4 out of 20 is still in the ICU care. So in conclusion, in this small cohort of patients, of long-term kidney transplant patients, SARS-CoV-2 induced pneumonia is characterized by high risk of progression and significant mortality. So what are the characteristics of the transplant patient who get COVID-19? They have diversified clinical symptoms. A lot of them are asymptomatic. They have low levels of CD3, CD4, and CD8. They develop more severe pneumonia. They have more rapid clinical deterioration, and they have higher and earlier mortality. So this is the guide in the management of the COVID-19 transplant patients. In the treatment, watch out for drug interactions. Like lopinavir, ritonavir can increase the levels of tacrolimus and cyclosporine, and modify the immunosuppressive drugs. It is advised that the cell cycle inhibitors be discontinued, calcineurin inhibitors be reduced in dose, and to give steroids but individualize the dose. Okay, so what is this? Because of the high mortality of patients, of the kidney transplant patients who develop COVID-19, a survey was done on 111 transplant centers in the United States, and this covered the period March 24 to 31. 88 transplant centers responded. And most of them, like 71.8% of them, have suspended the living donor kidney transplant program. For the deceased donor kidney transplant, they would do transplantation, but with restrictions. They would do the transplant for those who have who don't have a vascular access, those who are highly sensitized and were able to find a donor, and those with a negative cross match. In the Philippines, the Philippine Society of Transplant Surgeons made an earlier statement recommending that all living and deceased organ transplant surgical procedures be suspended indefinitely. Of course, we're going now to the new normal, and they're already formulating guidelines for resuming the kidney transplant procedures. But what are the challenges in doing a kidney transplantation during COVID-19? The SARS-CoV-2 infection could be missed in both donors and recipients who are asymptomatic owing to the sensitivity issues with your test, no? Because it is not, the sensitivity of this RT-PCR test not that high. So you could be transplanting a patient who tested COVID negative, but who eventually on retest would be found to be COVID-19 positive. There are scarce resources like beds, operating rooms, medics, and nurses. There's also this logistical difficulty in ensuring clean and microbiologically safe pathways within hospital for transplant patients. And of course, we have to consider the increased susceptibility to SARS-CoV-2 infection in the immediate post-operative period and after hospital discharge, owing to the induction therapy and immunosuppressive therapy. And sometimes it's going to be very difficult to perform emergency surgical procedures like doing a kidney biopsy for transplant rejection or allograft nephrectomy if the kidney is the focus of the sepsis, or open revascularization procedure if there is renal artery stenosis. Going to the hemodialysis patients, the hemodialysis patients comprise a distinct population in the COVID-19 era because, number one, we have a relatively large number of hemodialysis patients. In the Philippines alone, and this is an old is this from the old registry, now we have more than 70,000 patients on hemodialysis. In the United States, from the latest USRDS registry, 2019, the number of patients on hemodialysis is about 500,000. So there's really a lot of them. They need to come to the dialysis unit at least 3 times a week. And the hemodialysis patients are mobile. They travel from home to dialysis facilities and other healthcare settings, serving as potential vectors for infection. They also receive lengthy treatments in close proximity to other patients and dialysis staff. And we all know that hemodialysis patients have impaired immune function and have multiple comorbidities, hypertension, cardiovascular disease, diabetes. And here is a meta-analysis on the risk of the comorbidities for severe COVID disease versus non-severe. A hypertensive patient has a 2.36 times risk of developing severe COVID-19 disease. A diabetic patient has a 2 times risk for developing severe, but that's not significant. Those with respiratory problems will have a 2.6 increased risk of developing severe COVID-19, and those with cardiovascular disease will have the highest risk of 3.4 times developing severe COVID disease. So you see, these are all present in our hemodialysis patients. So most of our hemodialysis patients would be at high risk for developing severe COVID-19 disease. Let's look at the studies on the hemodialysis patients. This is just a description of the clinical characteristics of the COVID-19 in the hemodialysis patients in Wuhan. Okay. So in their dialysis unit, they had a 2% incidence. Okay. And the median age was 63.2 years. So the patients have many comorbidities. Cardiovascular disease was present in 68.7%, diabetes in 22.9%, COPD in 3.8% of those patients. And the clinical presentations are varied. And so you see here, fever is not always the usual presentation. It was only about 50% of the patients would present with fever, and the rest are the rest of the presentation are not even that common. The laboratory examinations would show lymphocytopenia, and the chest CT scan would show ground glass or patchy opacity in 82.1% of the patients. So now let's look at the clinical course and outcomes of 36 maintenance hemodialysis patients in Spain. Okay, so see the clinical course here, the same, not fever is not universal. Some of them would also show normal chest X-ray. These patients were placed on standard care. But look at their mortality. The mortality among these patients, among the hemodialysis patients who were hospitalized, is very high, 30.5%. So what are the predictors of mortality? Vintage. The longer time on dialysis is associated with higher mortality, increased LDH level, and decreased lymphocyte count. So the conclusion in this particular study is that mortality among hemodialysis patients with COVID-19 is high. Dialysis vintage, lymphopenia, and high LDH levels are markers of poor prognosis. Let's look again at another study. This one looking at all the patients on renal replacement therapy. 46% on hemodialysis, 4%, only 4% had peritoneal dialysis, were on peritoneal dialysis, and 51% are kidney transplant patients. So this is a total of 51 hospitalized This is a total of 51 hospitalized patients who were COVID positive. So again, presentation fever, only 55%, cough in 64%. And see, dyspnea was only present in 49% and GI symptoms in 28%. Was the median time to diagnose from the onset of symptoms. For the patient, for the hemodialysis patient, the median time to diagnosis was 1 day, but there was quite a delay in the diagnosis of the kidney transplant patients, 3 days. Only 61% of them presented with the ground glass opacities. And look at the mortality. 7 out of 28 died in the dialysis group, so that's about 28%. And 6 out of the 26 died in the kidney transplant group. So see again here the high mortality of patients on dialysis if they get COVID-19. Here's a bigger study involving 90 patients. 37 of them were managed as outpatient because of mild symptoms, mild presentations. And yet, despite presenting earlier with mild symptoms, 8% of them died. For those patients who were symptomatic and who were hospitalized, 21% did not even have a positive chest X-ray finding. And when hospitalized, the mortality is very high, 42%. So you see here that there is a variable disease severity for the SARS-CoV-2 infection, the hemodialysis patients. They are at high risk for ARDS and death. There's a high risk for ARDS and death in the subgroup requiring hospital admission. So because of that, a lot of centers now are doing their own algorithm in looking at all this, their patients. For example, in this particular hemodialysis unit in Wuhan, their screening procedures started with a chest CT scan because they can get instant results. The swab test takes time to, the results takes time to come out. So their initial screening test is a chest CT scan. If the patient does not have CT scan presentation of viral pneumonia, then he goes on routine dialysis, and the chest CT is repeated after 7 to 14 days of treatment. And if there is no progression in the CT scan, then he goes into his routine dialysis. However, for the patients with the CT scan finding of viral pneumonia, they divide the patient into 2, those with fever and those without fever. For those without fever, they just wait for the results of the swab. If negative, they're dialyzed in the isolation room and retest throat swab done. And if they positive, they're transferred to a COVID designated hospital. If negative, they do undergo antibody detection, repeat chest CT, and do routine dialysis. Now, what is bothersome here is that for those who were symptomatic and with the chest CT scan of viral pneumonia, dialysis was withheld until it was proven that they are COVID positive. And when they become, when it was proven that they are COVID positive, they are transferred to dialysis center of COVID negative patients. So you see here the importance of having a COVID negative patient, a COVID designated hospital. Okay. But bear in mind that if you do CT scan as a screening test, ground glass opacity finding is actually very common among the uremic patients. And this study of the high resolution CT scan before the COVID time already showed that uremic patients would have ground glass opacity finding in about 45% of them would have ground glass opacity. So there will be instances that patients will be mislabeled as COVID positive, will have their dialysis deferred while waiting for the CT scan, and by that time they have been exposed to the COVID floors. We must also remember that sometimes the dialysis patients cannot clear immediately their virus. In this particular study, where they did intensive monitoring of the presence or absence of the virus, 48 hours swabbing here, they only noted that in this particular cohort of 34 patients, only 20%, only 20 patients would have a negative RT-PCR test within 15 days, but 9 patients still were COVID-19 positive after 21 days. So it means that maybe our threshold of 14 days may not be very applicable to the dialysis patients because they may still be harboring the virus after 14 days. If we're going to look at the strategies done by the different dialysis centers, let's look first at what they did in Lombardy. They noted here they were monitoring the patients, and these are asymptomatic patients, and they were very worried that there was this increasing number of symptomatic patients who tested positive for COVID. But the most bothersome is that they also saw this ever-increasing number of healthcare staff being affected by or being infected by the coronavirus. So, and among these patients who were hospitalized because these were symptomatic, 52%, the mortality was 52%. So 13 died, only 7 improved, and 5 were still hospitalized. So what did they do? So they did the COVID testing in all the patients. And so what did they find? That they were actually dialyzing COVID positive and COVID negative patients in the same room. And that may be the reason for the escalation of the COVID cases in their unit. So getting the results of knowing now the status of these patients, they now segregated the COVID positive from the COVID negative and created this permanent barrier between the COVID positive and the COVID negative patients. And so what was the result of the study? So this was the time that they did their COVID testing, enhanced PPE, and segregation. And they were able to record only 3 more patients. And after that, there was flattening of the curve and the reversal of the curve. But what is more enlightening is that among healthcare staff, none of them developed COVID disease anymore after the testing. It is also enlightening that among their peritoneal dialysis patients, none of their peritoneal dialysis patients ever had COVID-19. And if you're going to go back to this slide I presented earlier, looking at the different patients, different ESRD patients, look at the patients on peritoneal dialysis. Only 4% got COVID-19. So that's just 2 out of 51. And so this emphasizes the need for self-protection, that self-isolation and home quarantine will actually be the best method for reducing or for not getting the COVID-19 infection. Okay. Here's another intervention for COVID-19 in Wuhan. Again, they saw this increasing number of patients getting COVID-19. And so what they did was to do measures to mitigate this increase in the COVID-19. They had strict entrance screening of temperature and symptoms. They have They had universal screening of pulmonary CT scan and blood tests, and isolation and triaging of confirmed or suspected maintenance hemodialysis patients, and a method of reporting. So because of the increasing number of COVID-19 patients, of positive COVID-19 patients, they designated 2 dialysis centers for just particularly for these COVID-19 patients. But because there was an increasing number, they designated 6 more dialysis centers. And after that, while there were new cases, eventually after a couple of weeks, there was a decline in the number of patients getting COVID-19, and eventually no more new cases where they were not able to find new cases anymore. So what are the interventions that might mitigate the spread of COVID-19? Of course, the hand washing and self-isolation and home quarantine, these are very important. But in addition to that, the testing of all hemodialysis patients for SARS-CoV-2, which was the intervention done by the dialysis unit in Lombardy, the upgrading of the PPEs of the healthcare staff, the segregating and cohorting of patients, and designating dedicated hemodialysis units. These are additional interventions that mitigated the spread of COVID-19. Of course, it is predictable that in this pandemic, there's going to be equipment and personnel shortages. And that is why it's very important for us to develop flexible algorithms and coordinations and sharing resources. And again, we must emphasize that we need designated COVID dialysis unit. So in summary, for the hemodialysis patients, these patients present with wide range of symptoms, with a significant portion being asymptomatic. There is a prolonged positivity of pharyngeal swabs. The maintenance hemodialysis patients are at increased risk for COVID-19 and its complications due to presence of multiple comorbid conditions. The logical aspects within the dialysis facility further increase the risk of disease transmission. And take note that if our patient develops COVID-19, the mortality is very high, 25 to 30%. So let's look at the hospitalized patients. There's a high prevalence of acute kidney injury in hospitalized patients, and this meta-analysis would give us a prevalence of about 0.83. No? 0.83 is 0.83%. You might think that is not very high, but if you're looking at 76 or almost 77,000 patients, then you're looking at around 700 patients who develop acute kidney injury. Here's the data provided by the International Society of Nephrology. The incidence of AKI is, you have a wide range here in various centers from 0.5% to 29%. Of course, it's going to be more common in the ICU setting, 8.3% versus 2.0% in the non-ICU setting. The need for CRRT, also you have a wide range here, 0.8% to 17%. And you have a lot of urinary abnormalities, albuminuria, proteinuria, and hematuria. These patients who develop AKI have many comorbid problems. CVD in 40%, an underlying chronic kidney disease in 0.7 to 48%, diabetes, and hypertension. So let's look at the association of kidney disease in hospital death of COVID-19 patients. So we have here 701 patients with COVID-19, and they were able to note biochemical abnormalities in proteinuria in 43.9%, hematuria in 26.7%, increased creatinine in 14.4% of the patients, and the incidence of AKI is 5.1%. Now, Look here, the hazards ratio for death. If your patient has proteinuria, then there is an increased risk for death. And the higher the proteinuria is, the higher the risk of death. If the patient has hematuria, then you have here a 3 times increased risk of death. And the higher the hematuria is, the higher is the increased risk of death. AKI also is associated with increased risk for death. If a patient develops AKI at stage 2, there is a 3.53% increased risk of death. And when the patient is diagnosed to have stage 3 AKI, the risk of death is 4.72%. So development of AKI in the in-hospital setting is associated with high mortality. Let's look at this cohort of patients from 13 hospitals in New York who were tested, who were diagnosed to have SARS-CoV-2. And the mean age of this patient was 64 years, a period spanning a month. Okay. So the incidence of AKI was very high, 37%. And these are the risk factors for AKI: older age, Black race, hypertension, diabetes, cardiovascular disease, vasopressor use. But the need for ventilation is highly associated with the development of AKI. In fact, in this particular graph, you can see that the development of AKI almost coincided with the initiation of mechanical ventilation. So among these patients who developed AKI, 35% died. Only 26% were discharged, and a high number of these patients still admitted. So in conclusion, we can say that AKI occurs frequently among patients with COVID-19. It occurs early and in temporal association with respiratory failure. And AKI in COVID-19 is associated with poor prognosis. The kidneys are really affected by COVID-19. And this is a report on the autopsy findings of COVID-19 patients. This is from 26 patients, but look here, only 9 of them showed clinical signs of kidney injury. But despite that, they would see these findings, the typical findings: RBC aggregates in the peritubular capillaries, evidences of acute tubular injury, and they were able to see on electron microscopy the presence of virus in the tubules and in the podocytes. And you can see that here better when they did the staining of the SARS-CoV-2 nuclear protein. So there is evidence of direct parenchymal infection of tubular epithelial cells and podocytes with marked acute tubular injury and erythrocyte aggregation, which occurs in those patients who died. Okay, another study on the presence of SARS-CoV-2 receptors, or the ACE2 receptor, in the kidney. Most of the ACE2 are concentrated in the proximal tubule, and that's the reason why acute tubular injury is very common. It is very concentrated in the proximal tubule, but most especially in the S3 segment of the proximal tubule. There are also receptors in the podocytes, in the mesangium, and in the endothelial capillary. But most of them are concentrated in the proximal tubule. And the antibodies and ACE2 is highly expressed in the COVID-19 patients. This is a comparison of the antibody staining for ACE2 in the non-COVID patient. You can see that if you compare this staining with this staining, you can see that you have a lot of COV2 receptors in the COVID positive patients. Okay. There's also another etiology of the acute kidney injury, and this is the presence of the collapsing glomerulonephropathy. And this collapsing glomerulopathy there's been an increasing report of collapsing glomerulopathy in the COVID-19 patients. So on biopsy or histopath of these patients, they would see the collapse of this glomerular tuft, okay, and the proliferation, hypertrophy, and hyperplasia of the epithelial cells. Okay, here's another biopsy of a patient who had collapsing glomerulopathy, a COVID-19 positive patient who was diagnosed to have collapsing glomerulopathy. Okay, again, you see here the collapse of the glomerular tuft, and you have here a higher degree of glomerular tuft collapse and the proliferation of the epithelial cells. Okay, so these are the epithelial cells that have proliferated. Okay. So collapsing glomerulopathy is not really that uncommon. It has been shown to be, it has been seen in this genetic variants where you have this nuclear genomes and mitochondrial genomes among users of pamidronate or patients who were given pamidronate, interferons, and anthracyclines. Systemic diseases like SLE and vasculitis can also produce collapsing glomerulopathy. And acute glomerular ischemia can also cause collapsing glomerulopathy when you have thrombotic microangiopathy, atherosclerotic disease, and sickle cell disease. But it is also very common among it is also very common in infectious diseases, HIV, HTLV, CMV, parvovirus, Epstein-Barr virus. And now you have here the addition of SARS-CoV-2 in the list of viruses that can cause collapsing glomerulopathy. Okay, so what is the pathophysiology of AKI in the COVID? It can be divided into four mechanisms. First is the activation of the angiotensin II. Okay, so because the ACE2 had been used up by the virus, then there is activation of angiotensin II with complement activation, and there's increase in hypercoagulability and microangiopathy. Second is the cytokine storm. There's lymphopenia and myeloid cell activation and release of all those cytokines. Third is direct viral invasion. And we have shown earlier that you have your ACE2 receptors, you have your ACE2 you have a lot of ACE2 in the kidney. In fact, the amount of ACE2 in the kidney is said to be nearly 100 times that of the lungs. Okay. There can be also viral invasion of the muscles, which lead to rhabdomyolysis, and this can contribute to the development of acute kidney injury. However, what we should not forget is this crosstalk between the organs, the extrarenal organs and the kidneys. The crosstalk between the heart and the kidneys, and the crosstalk between the lungs and the kidneys. And that can contribute to the acute kidney injury. This is an algorithm which is provided to us by Professor Ronco. Okay. In the management of acute kidney injury, which necessitated renal replacement therapy in the COVID-19 patients. So you have here critically ill patients with AKI necessitating renal replacement therapy. Ask yourself, what are the indications? So indications will be oliguria with refractory hypervolemia, hyperkalemia, severe acidosis, and azotemia. These are our usual indications for doing dialysis. However, in the presence of cytokine release syndrome, consider extracorporeal techniques for cytokine removal even in the absence of AKI. Consider also the need for multiple organ support like low flow echo, and consider running the renal replacement therapy in conjunction with ECMO. So what are the preparations? The vascular access must be greater than 12.5 French, preferably using the right jugular vein. Anchor firmly to avoid displacement, and don't use this to connect to the ECMO circuit. Ensure availability of your needs. Then what will be your prescription? Select your CRRT as preferred modality in CVVH or CVVHD mode. The blood flow should be higher than 150 ml. Select the anticoagulation which you are comfortable with. Regional citrate anticoagulation, low molecular weight, or unfractionated. And this is the dose. These are the doses that he recommends. Prescribe a dose of CRRT at 25 to 30 ml per kilogram per hour, targeting a minimum delivery of 20 to 25 ml. And take a tight note of, do a tight fluid balancing here. So what to avoid? Avoid recirculation, avoid filtration fractions, okay? And check the catheter position after pronations, check circuit patency, and monitor your, if you're using anticoagulation, these are the things that you need to monitor. Okay, so here's the hemoperfusion, and you can connect this with your hemodialysis procedure. Now, looking at the cytokine storm, your patient, here's the coronavirus, which has attacked the lungs, and this releases cytokine. So you have this phase of pro-inflammatory mediators. Now, the lungs need support, and your patient undergoes mechanical ventilation or undergoes ECMO. And both these interventions can also cause or generate cytokines. So you have these pro-inflammatory cytokines, which now will elicit the anti-inflammatory cytokines. And now you have a battlefield here in your body, which now causes great devastation. So what has happened here, as what Professor Ronco has said, si vis pacem parabellum, if you want peace, prepare for war. So be ready, prepare for the surge of your cytokines. You can do this by doing hemoperfusion to lower down the cytokine level, and so the anti-inflammatory levels will also be lower. There are many types of cytokines, and the interferons, the interleukins, but interleukins are really the ones which are pro-inflammatory. You have chemokines too, which are pro-inflammatory. And let's look at the way by which these are removed by the different sorbents in hemoperfusion. Here is a study utilizing cytosorb. And if you're going to look at the levels of the interleukin 6, interleukin 10, and tumor necrotic factors, you can see that after just the usual dose they did for the cytosorb therapy was an average of 1 to 3. So this means that even after one cytosorb therapy, the levels of interleukin 6, levels of interleukin 10, and the tumor necrosis factors significantly were reduced. And these were done on patients with septic shock. Here's another study on the changes in the humoral mediators after hemoperfusion. This group underwent hemoperfusion, and this is just a control group. And you can see that even after 1 day of hemoperfusion, interleukin 8 level has gone down, but there was no change in the control group. And here's the level of interleukin 6 among patients who underwent adsorption or hemoperfusion. Interleukin levels went down. This is baseline, this is day 2, this is day 3. Okay. Now, better clinical outcome is seen if hemoperfusion started earlier. And this is the comparison of the survivors among those who had hemoperfusion done early, that is less than 48 days after admission to the ICU. And this group they had lesser survivors if the hemoperfusion was done more than 48 hours after ICU admission. And length of stay in the ICU is much reduced if among the survivors if hemoperfusion was done earlier. Again, comparing the effect of hemoperfusion on extrapulmonary sepsis, there is much shorter duration of mechanical ventilation days. Mechanical ventilation free days is longer. Duration of CRRT is shorter. Length of ICU stay is shorter. ICU mortality is lower, and 20-day mortality is much lower. So this study was done among 46 patients with acute lung injury from extrapulmonary sepsis. So this is my last slide. So what are the key points here among patients with acute kidney injury? Acute kidney injury is frequently observed in ARDS patients affected by different comorbidities. And this was findings observed in the Wuhan COVID-19 infected patients, as well as the other patients in areas most affected by the coronavirus pandemic. ARDS-associated AKI may be ascribed to several causes, including an inflammatory immune reaction characterized by an enhanced release of circulating mediators able to interact and damage kidney resident cells. Organ crosstalk is an important cause of AKI. The kidney epithelial cell viral infection may worsen the local inflammatory response and consequently the incidence and the duration of AKI episodes. The use of extracorporeal blood purification techniques and antiviral therapies may theoretically limit the systemic and local inflammatory response, at least in part responsible for multiple organ failures, including AKI. And always remember that mortality of COVID-19 patients who develop AKI is high. Thank you very much.
Thank you, Dr. Montemayor, for that very comprehensive lecture. Indeed, COVID-19 has really changed and continues to change not only our daily lives, but also our practice of nephrology. I will now be reading the questions raised by our viewers here in the Q&A box. First, there's this question by Dr. Lagonzad. Would it be prudent to have all patients on maintenance hemodialysis undergo RT-PCR tests for COVID-19? And if yes, how frequent?
That is ideal. That is ideal, but of course we have to weigh things. No, it is ideal, but will it be practical? That is the question. Can the patient afford the cost of the test? Can the institution accommodate the need for the test? Okay. So it's really ideal because it is best to segregate the asymptomatic, because we're talking about the asymptomatic patients here, to segregate the asymptomatic patients from the truly negative patients.
I agree, ma'am. In an ideal setting, ma'am, how frequent should we test these patients, ma'am?
In the study, they only did a first testing, and then after that, they segregated the patients already.
Okay.
So after
Okay.
that, they were not able to identify any more patients who tested positive.
Okay, ma'am. Thank you po. Next question. What are the recommendations for dialyzer reprocessing and reuse for COVID suspect and for probable COVID patients and confirmed COVID patients po?
For the COVID-19, symptomatic COVID-19 patients, it is best not to reuse the dialyzer.
Not to reuse. Okay.
But if there is a need because of the lack of supplies, and that is the one that's going to matter here, the lack of supplies, the usual procedure for reuse of the dialyzer will be, is the recommended method.
Okay. How about any recommendations for dialysis machine disinfection after being used by a suspected or a confirmed COVID patient?
Again, the usual recommendation for the disinfection of the machines, no? So you need to use,
Usual.
yeah, the usual Clorox or we have certain guideline for which I did not present anymore. The ISN has certain guideline. The ERA-ETA has certain guideline, and they unified their guidelines. No? So I could,
Thank you.
but they
So
can
just direct them to read the
they-
ISN guidelines.
just go to ISN, and there's going to be this guideline for disinfecting, taking care of your patients on dialysis.
Thank you, ma'am. For this next question by Dr. Ann Ang, ma'am, can you please comment on the CDC recommendations to dialyze patients with suspected or confirmed COVID-19 at a corner or end row station away from the main flow, separated by at least 6 feet from nearest patient if no isolation room is available?
No, I don't think that is a good idea to not cohort or not segregate the patient. So what is best is to do this, to do dialysis on these patients at the last shift when there are no more non-COVID patients. So I think that's part of cohorting your patients. Do this at the last shift, but the personnel must have enhanced PPE, and after their dialysis, there's going to be disinfection of the machines and the beds and the tables. So an enhanced disinfection program. Of course, the next day they can again use these machines for the non-COVID patients. No, for as long as you don't dialyze the patient, the COVID positive patients in the same area, whether it's in the corner of the room, they have to, there must be some sort of a barrier.
Segregation, yes.
Segregate, cohort. So that's a key there, segregating and cohorting them.
Thank you, ma'am. Next question. On electron microscopy, it was shown that the virus is present in the tubules. Does this mean that the virus is also excreted in the urine? Hence, COVID can be contracted when sharing bathroom with asymptomatic COVID positive patients?
The presence of the virus in the urine has been documented already. But I don't know if you can get COVID virus, you can get COVID disease in the bathroom, because remember that the spread is through droplets, no? So you must also inhale the virus for it to gain entry into the lungs. But it has been documented. The virus in the urine has already been documented. They were also able to document virus in the stool. And because this ACE2 is present in almost all organs of the body.
Okay, so it's still best to wash your hands and wear a mask even in the bathroom.
Yes, in the
Okay,
bathroom,
next,
yes. If you urinate,
especially
wash your hands for 20 seconds.
20 seconds.
The washing of the hand does not include what yung the water, yung rinsing does not include rinsing. It's just soaping. So 20-second is pure soaping.
Okay, thank you, ma'am. Next question: are there institutions doing ECMO for our COVID patients? And if yes, how is the outcome of those patients?
Yeah, I think they've done this they have in NKTI and St. Luke's, no? So probably Russell can answer this. What is the outcome of your ECMO of your patients who were placed on ECMO? If Vimar Luz is also here, maybe he can.
Hi, ma'am. Currently, we don't have a case who underwent ECMO for COVID-19, though we have cases who underwent hemoperfusion. It's just because the setup that we have was outside the hospital, and thus we can't bring the ECMO out in our tents.
So, Vimar, are you here? Maybe you can answer the question.
Doc Vimar, are you here?
Okay.
So I think that may be the answer for that. We have a question here in the chat box from Dr. Steph Andres. She typed, knowing that HD patients are at a very high risk for severe COVID disease, do you think it would be wise for PSN to push PD for your ESRD patients? And perhaps it would be good also to get a survey of how our existing PD patients are doing during this pandemic. So it would give us a good idea if PD is more beneficial for our patients and the basis for pushing for it or not.
Yes. In the other institutions in Italy, realizing that there is a dearth of they have a lot of patients on dialysis, and they lock the machines and the personnel. They actually have been utilizing PD, and there have been results. The results have been very good. What is very good with the peritoneal dialysis patients is that they don't go out, they just stay at home. And so based on the reports in various dialysis centers, the incidence of COVID-19 among the peritoneal dialysis patients is almost 0 to 2%, 0.4%. So very, very low.
Dr. Vimar is present. I think he wants to say something.
I'm sorry. A while
regarding
ago,
anything. Yes,
a
sir.
while ago, I wasn't able to get into the microphone.
Okay, sir.
We haven't done ECMO except for just one patient, but it's actually way after already that the COVID in itself is, I mean, the complications of COVID have been improving. So in other words, he has other problems.
Okay.
We have problems doing ECMO because, for one, there are documented cases of increased hyperinflammation when you do ECMO, which was some experience in Europe that it made them even more prone to precipitating a progressive cytokine release. The other comment I would like to make in terms of standard cleaning, actually the recommendation does not change. The standard recommendation of how we clean our present machine is the same. And it's supposed to cover for COVID virus as well. Thank you.
And for, I think some other panelists answered the question regarding the experience on ECMO. From Dr. Biruar, he mentioned no ECMO done among COVID-19 patients in Makati Med and also done in St. Luke's. And Dr. Tanchanko mentioned there's one patient on ECMO now in TMC, but still the early course. So maybe as the core, as the pandemic, as we will have more experience regarding ECMO. Ma'am, next question. What is the threshold for doing CT scan of the chest among dialysis patients?
It depends. It depends on, in one center, that's the standard. That's their universal screening procedure. Now, as I've mentioned earlier, you can do your own algorithms. The algorithms, you can do your own algorithm, but it should be flexible enough to adjust to what the patient has or what the patient needs and what the resources are.
Okay, ma'am. This one from an anonymous. Ma'am, is tocilizumab dialyzable or removed by hemoperfusion?
Well, in a webinar that I attended, and Dr. Ronco was the speaker, he said that tocilizumab is removed by hemoperfusion. But tocilizumab is a very big molecule. It has a molecular size of 165 kDaltons.
Oh.
Yeah. And the usual sorbents that we have can remove on the average up to just about 50. So if we base it on that, then we can say that tocilizumab may not be removed by the usual sorbents that we have. But hearing it from Professor Ronco, that he said that if you do hemoperfusion and you have given tocilizumab, that you have to give another dose of toci.
Ma'am, also about dialysability, are immunoglobulins in the convalescent plasma therapy removed during hemoperfusion?
Again,
and what is the recommend?
I haven't checked
Yes,
the molecular size of the immunoglobulins, but if they are, as I said, you know, the maximum size that the sorbent can remove is about 50 to 54 maybe. And tocilizumab is 154, 164, I cannot remember. So ideal tocilizumab is not dialysable, but Professor Ronco said it is dialysable. So I cannot argue with Professor Ronco. So in immunoglobulin, maybe I have not checked on the molecular size of the immunoglobulin. So it really depends on the molecular size.
So is it best to give it after hemoperfusion session?
Yes, yes.
Okay.
I think it's best to do first your hemoperfusion. The first, like before you give the tocilizumab attacks interleukin 6. So what you can do is do the hemoperfusion first to bring the level of your interleukins down, and then give the tocilizumab so that it can cover the remaining ones. It's like, you know, going to the battlefield where you have to attack first the many, and then the general now comes in and there are few enemies left.
Next question, ma'am, from Dr. Estrella. Wouldn't hemoperfusion be more affordable and more available? I think maybe the doctor is referring compared to CRRT.
They have their own indications. Hemoperfusion is only for cytokine storm, whether it's here in our pandemic or in sepsis, which is non-COVID related, you can do that. So hemoperfusion is only for cytokine storm. But of course, the CRRT is for the indications for doing the dialysis.
Yeah. Okay. Thank you, ma'am. Next question. In the Wuhan study, if the initial swab is negative, do they repeat? And what is the lead time before repeating?
They usually do that after 48 hours. So as I said, they were doing it intensively every 48 hours until they get a negative test. And once
Negative.
they get a negative test, they repeat it for 48 hours again. And then when they get a negative test, then that's it.
Next question, ma'am. For those discharged patients who underwent RRT during confinement, any reports on the percentage of patients who eventually needed chronic renal replacement therapy?
For the AKI who...
Yes, ma'am. Who developed maintenance, who did maintenance hemodialysis or dialysis?
I have not come... parang wala sa mga in the literature or in the studies that I have presented to you. When they're discharged, they are free of dialysis.
Okay. Next question. In your review of AKI, is there a racial predisposition, or is it just because of better management as we proceed and learn from the other countries? The article by Professor Battle says it's more severe in the West, Occidental, than Asians. This is from Dr. Lynn Gomez.
I don't know. In the report in Wuhan, they only reported an incidence, AKI incidence of 2%. In the report in Lombardy, the incidence is 14%. So we don't know. So we don't know whether it's just better recording or better reporting or...
Yeah, okay. I hope that answered Dr. Lynn Gomez's question. Next one, ma'am. There are lots of questions coming in. Would you recommend not to start an ACE inhibitor, an ARB, in a hospitalized COVID patient who is a newly diagnosed hypertensive or diabetic?
Yeah, to start, maybe I'm not going to start. I will wait
should be
until
recovery.
He becomes negative or he recovers.
Okay. Should we, this again from Dr. Lynn Gomez, should we now drop chloroquine from the list of medications that we use for COVID-19 patients?
Because of the negative result?
Negative result.
It is an option. It is
option. Still an option.
Yeah, if you're a Trump, you're going to use it.
Okay, shade. Do you have COVID-19 patients who use Hualien, Chinese medication? What are your thoughts regarding this? Hualien?
I don't know. I'm not familiar with the drug, so I don't think I can answer the question.
Kindly, this is from Dr. Julio Serrano. Kindly comment on most tests being ordered as part of for COVID workup, as most of these are abnormally elevated in CKD patients due to non-specific inflammatory states such as CRP, ferritin, and LDH. It does not seem to be cost-effective.
No, but for cytokine storm, the level is really very high. So for CRP, for example, if you want to make a decision on whether you want to do hemoperfusion, okay, there are cutoffs there, CRP of 100 or 90, I think, ferritin levels above 1,000. So these are really very high levels, and which are not commonly seen in the usual stable hemodialysis patients. Of course, you can also go by the trend, no? So is the trend rising? So if the trend is rising, then you should be alarmed and maybe prepare your patient for a possible, be ready for a possible cytokine storm.
Cytokine storm.
Yes.
Okay. From Dr. Cha Escobin, if the COVID positive dialysis patient has already recovered and tested negative, how soon can the patient return to regular schedule and stop cohorting?
Two negative. Well, the advice is if the patient has been asymptomatic 14 days after the onset of after the last symptom presentation, and 2 negative testing.
So 2 negative testing. So they can be back to their regular.
Yes, they can go back to their home unit.
Okay, thank you, ma'am. Last question, can you comment on the non-transmissibility of the virus among recovered patients who remain positive for the virus by PCR? Because there is an article in Korea, from Korea, that conclude that these patients are no longer infectious.
Because the PCR checks parts of the virus.
Viral.
Yeah, so maybe the positivity there are just remnants of the virus and not the virus, not the virus already. So that may explain the non-contagiousness of
Transmissibility.
the non-transmissible. So maybe they don't have the virus anymore, but they just have the remnants of the virus which were picked up by the test, by the PCR.
Okay. One last question, ma'am. Are there any recommendations regarding testing for dialysis patients coming home to the province? I think this Dr. Leslie Yap is pertaining to patients coming from the NCR coming home to the provinces.
So maybe since it is very endemic in the National Capital Region, and it depends really on the prevalence.
Capability.
It depends on the prevalence of the prevalence of COVID positive in the area. So if there's a high prevalence, then it is best to check. If there is a low prevalence, then you just observe.
Okay. Follow-up question, ma'am, from Dr. Escobin. If the RT-PCR is not readily available and patient has been cohorted for more than 2 weeks and patient already has been asymptomatic for more than 1 week, do we maintain them on a cohort and until when?
Since a lot of patients still, we're talking about hemodialysis patients, still remain COVID positive after 14 days. So maybe we should have a higher or a lower, what do you say? Higher threshold means longer period of isolation for a hemodialysis patient. So maybe we can extend it to 21 days, especially if you don't have the results of the PCR testing.
This is compared to the regular 14 days, ma'am, no?
Yeah,
so for dialysis patients, it's more, we'd want a longer time. Okay, just to be sure.
Okay. If you don't have the results of the negative test, maybe you can extend it, the period of isolation to more than 14 days.
One last, ma'am, sorry. Ma'am, many dialysis centers require a negative swab before accepting new patients, even if they are asymptomatic and with normal chest x-ray. Is this acceptable, and what can we do about this?
You know, it really depends on the screening procedures of the certain dialysis unit. As I said, you can develop your own algorithm. Your screening test may be a chest x-ray, your screening test may be a CT scan, your screening test may be an RT-PCR, but you just also have to consider, as I said, the resources, the capability of the patient. We cannot just do all the COVID testing, for example, because let's say we have 70,000 patients on dialysis. We cannot request for RT-PCR for all of them. So we just really have to make an algorithm. So if that dialysis center makes that certain algorithm, then they just have to follow that. Wala.
I think we lost Jan.
I guess we lost Jan, so maybe I'll step in.
Just continue, Russell.
I'd like to thank you, Dr. Montemayor, for a wonderful discussion and for answering all the questions that were asked by our participants. I think it's a successful webinar. And we look forward for our participants to join us again next Wednesday as we had Dr. Luis Limchu discussing the rational use of diuretics in the kidney disease patients. So I'd like to thank Dr. Montemayor. Of course, Dr. Jan is back. There was just
Sorry.
a little loss in
Technical.
the internet signal. But again, thank you everyone, and keep safe, and we look forward to seeing you again next week. Thank you.
Thank you very much. And I'd
Thank
like
you.
to thank everyone of the business meeting and elections on July 12. Please, please attend the business meeting and cast your votes. Thank you very much. Good night. Fin-